Don't worry about the destination. Enjoy the journey. And the more you enjoy the journey, the more are the chances that you will keep walking. And if you keep walking, who can stop you from reaching your destination? Yes, to reach the destination, only two things are required. First, your route should be correct. The path on which you're walking should. When you're doing any work, do not think of anything beyond. Just devote your whole life for it for the time being. Yes, this is, in simple words, called whatever you are doing, do it with full only practice traction. Every time you will become better at it. If you practice concentration every time, you will become better at it. And this mind is the instrument that you have. Yes, like as surgeons, we always choose the instruments which are the sharpest, that will make our surgery very, very easy, very, very effortless. So this is the instrument. Your mind is the instrument that you have, and that is to cut anything, that is to simplify anything in your life. So don't you want that instrument to be sharp? What is the way of sharpening it? Concentration. Practice concentration the whole day. The more you practice anything, the better you become at it. Whatever you're doing, do one thing at a time, only with that focus, and you see how your concentration increases. So with that note, we are going to now start with the anatomy of the external ear. Now, in the anatomy of the external ear, we first start with the anatomy of the pinna. Now, before we start with the anatomy of the pinna, it is now first your task. You will tell me, from where does the pinna develop? Tell me, pinna develops from where? Yes, from which arches? First and second arch. Which part of the pinna is from the first arch? Tragus. Rest of the pinna is from second arch. Fusion defect of the auricular tubercles leads to, yes, preauricular sinus. What's the most common site of preauricular sinus? Yes, so this was a question that was asked in your exams, and look at the choices. The choices were helix, tragus, antitragus, root of it. When you're doing any work, do not think of anything beyond. Just devote your whole life for it for the time being. Yes, this is, in simple words, called whatever you are doing, do it with full concentration. And how can you do it with full concentration? Yes, that is not something which comes very easily. That has to be practiced. That is a training. How can you do that? Yes, whenever you are doing anything, do only one thing at a time. Do only practice concentration the whole day. When you are studying, don't look at your phones. Keep it in silent mode. Keep it away for half an hour, for 1 hour. Increase the duration. What are you doing? You're practicing concentration. If you practice distraction, every time you will become better at it. If you practice concentration every time, you will become better at it. And this mind is the instrument that you have. Yes, like as surgeons, we always choose the instruments which are the sharpest, that will make our surgery very, very easy, very, very effortless. So this is the instrument. Your mind is the instrument that you have, and that is to cut anything, that is to simplify anything in your life. So don't you want that instrument to be sharp? What is the way of sharpening it? Concentration. Practice concentration the whole day. The more you practice anything, the better you become at it. If you're doing one thing at a time, only with that focus, and you see how your concentration increases. So with that note, we are going to now start with the anatomy of the external ear. Now in the anatomy of the external ear, we first start with the anatomy of the pinna. Now before we start with the anatomy of the pinna, it is now first your task. You will tell me from where does the pinna develop? Tell me pinna develops from where? Yes, from which arches? First and second arch. Which part of the pinna is from the first arch? Tragus. Rest of the pinna is from second arch. Fusion defect of the auricular tubercle leads to, yes, preauricular sinus. What's the most common site of preauricular sinus? Yes, so this was a question that was asked in the exams, and look at the choices. The choices were helix, tragus, antitragus, root of helix. Yes, which means that we need to know exactly what the parts of the pinna are. So yes, the first thing that we need to know in the pinna anatomy is the parts of the pinna. So let us quickly see what the parts of the pinna is. Yes, so this part of the pinna is what is known as the tragus. We know that. Now this here is the helix of the pinna. This part of the helix is what is known as the ascending crest. Ascending, it is ascending up, so it is known as ascending crest of helix. Of helix. Yes. Now this helix goes down like this, and it ends into this part of the pinna, which is known as lobule. And lobule is a part which only contains fat; it does not contain cartilage. Now here, just in front of the helix is another prominence. This prominence is known as antihelix. You can feel in your pinna also the parts of the pinna. Yes, this here is the helix. Just feel the antihelix. Yes, this is the antihelix, and this antihelix ends below in a prominence like this, just in front of the tragus. This is what is known as the antitragus. This is known as antitragus. Opposite to the tragus, so it is antitragus. Yes. Now this helix goes superior and it divides into two crusts, an inferior and a superior crust. And this area in between these two crusts is what is known as the triangular fossa. Triangular fossa. And this area in between the helix and the antihelix, this is what is known as scapha. Scapha. Yes. Now in front of the antihelix, this area behind the tragus, we have the external opening of the ear, that is external acoustic meatus. Behind the external acoustic meatus, or if you keep your fingers there, yes, this area, this is what is known as the concha. This is known as concha. And now from the concha, take your finger superiorly. Take your finger superiorly. Yes, it goes into this depressed area. In above the concha, this is a very, very important area of the pinna. This is what is known as Symba concha. This is known as Symba concha. Symba conchae. Now, what is the significance of the Symba conchae? This is a cartilaginous landmark. Cartilaginous landmark for mastoid antrum. For mastoid antrum. Now, when I say cartilaginous landmark means it is telling you something about the position of the antrum. So, if this is a landmark for antrum, this is telling you about the position of antrum. Tell me, where is the antrum? Where's the antrum? Yes, just medial to it. Just medial to it on the bony part of the mastoid. We have the bony landmark for mastoid antrum. So we have removed the pinna here, and here we have somewhere the Symba conchae area. So just medial to it on the bony part of the mastoid is an area which is known as Mech-Evers triangle. Mech-Evers triangle, and this Mech-Evers triangle is the bony landmark for mastoid antrum. Bony landmark. So we now know of two landmarks for mastoid antrum, bony landmark of mastoid antrum. So two landmarks we know, one is cartilaginous and the other is bony. Now what exactly are the boundaries of the Mech-Evers triangle and where exactly lies? All that we'll see later on. But now just tell me, why you told me we need two landmarks for the mastoid antrum? Yes, if we know that if there is any disease in the mastoid antrum, just we can start drilling anywhere behind the pinna. If you start drilling anywhere behind the pinna, will you ultimately not reach the mastoid antrum? Why do you have to remember that you have to drill only just near to the Symba conchae? That is the Mech-Evers triangle. Drill only here. Don't go superiorly. Don't go posteriorly. Don't go inferiorly. Why not? Yes, why? Because superiorly, we have this superior part. This is what is known as the dural plate. Dural plate, yes, because it is separating the mastoid antrum from the dura of the middle cranial fossa, which means if you go a little superiorly, you will be into the middle cranial fossa. Now here posteriorly, we have this plate of bone. This is known as the sinus plate. Sinus plate, why sinus plate? Because here we have just posterior to this plate, we have the sigmoid sinus. So you cannot go posteriorly, you will be injuring the sigmoid sinus. And inferiorly, what do we have? Yes, inferiorly, we have the mastoid tip, below which is the stygmastoid foramen, from which is coming out the facial nerve. So we cannot go inferiorly also, because there are such important structures all around the mastoid antrum. We want to remove the disease, yes, but not by damaging all these structures. We want to remove the disease without damaging all these structures. So we need to exactly know where we have to drill and what is that area, what are the landmarks, the cartilaginous landmark, you show me that, is that Symba conchae. At the bony landmark, that is the Mech-Evers triangle. Yes, once in our Viva, when we were pre-final, one of our examiners, he just had the habit of asking, oh, what happened to your Symba conchae? And you notice something over here, and you immediately, what Symba? That is the only thing he will ask, and then he will tell it, okay, go. So exactly if he says that what happened to your helix, you have to immediately take your finger here. Yes. If it's anti-helix, you have to take it here. If it is Symba conchae, you have to see what is happening to your Symba conchae. Yes. So maybe one of the examiners is also like that. So anyway, this is a question that is asked in exams. Symba conchae is the cartilaginous landmark. Now this pinna becomes a hindrance whenever we want to operate on the tympanic membrane, whenever we want to operate on the external auditory canal. Yes, can you imagine you have to operate here? So this becomes, this does not improve your exercise, that limits your movement of the hand, limits your movement of the instruments to go and operate inside the external auditory canal or the tympanic membrane or the middle ear. So do you know what we do? We remove the pinna out of our surgical area. Yes, actually we do that. How do we do that? We give post-oral incision. Can you see this? Yes, a post-oral incision is given, and here can you see the Post-oral incision is given and the pinna is just retracted forward. You see here, yes, the pinna is this area. The pinna has been retracted here. The pinna has been retracted forward that you cannot see. Yes, it has been retracted forward, and with the help of retractors, the pinna is now out of view. This is the area of the external artery canal, and this is the mastoid area. Now, if you want to operate on the mastoid, operate on the mastoid. You want to operate on the external artery canal, tympanic membrane. There is no hindrance of this cartilaginous structure. You can easily access these structures. So, but suppose if there is very little work that you want to do in the external artery canal, or very little work on the middle ear or on the tympanic membrane, do you want to get such a big incision? No. So then what we do is we plan to go through the external auditory meatus from here itself. But this is a very narrow area. We know it is cartilaginous. It is very narrow. So what we want to do is we want to give an incision around the meatus so that at least this area widens and the axis improves. So if you want to give an incision to widen the external acoustic meatus, this is cartilage, here there is cartilage, here there is cartilage, and if we give an incision at the cartilage, then do we know one specific feature of the pinna? You just feel your pinna and see. You just feel your pinna and see. Just below the skin, what do we have? We have the cartilage. Whereas here or rest everywhere, we have the skin, we have the muscles, then we have the cartilage or we have the bone. But here just below the skin, we have the cartilage overlying, which is the pericardium. So the skin is very tightly attached to the underlying pericardium, which means any little incision you give, the chances of if infection occurs going to the pericardium is very high. So whenever we want to give an incision to widen the external acoustic meatus, to approach the external ear, external artery canal, tympanic membrane, middle ear, we always want to avoid giving incision on the cartilage. Is that possible? Yes, it is possible. How is it possible? Just look at this cartilage. We know that pinna develops from two arches, but ultimately when the hillocks fuse, they form one single cartilage. Yes, there's a single elastic cartilage. And just look, everywhere it is cartilaginous except for in between the tragus and the helix. This area. So this area in between the tragus and the helix, this is the area where there is no cartilage. This is the area where there is no cartilage. Can you see? So whenever we want to give the incision, this is the site where we give the incision to widen the meatus. Now when we give an incision post-orally, this is known as post-oral incision. Post-oral incision. The name of this incision is wide incision. We will do all this again in detail later on. This is wide incision. Yes. But if we want to go through the external acoustic meatus by giving an incision here, that is something like this. Yes, we give incision here at the area where there is no cartilage. This incision is what is known as end-oral approach. End-oral approach. So what is asked in your exam is that what is the site of incision in end-oral surgeries of the ear? Yes, so what is that site of incision? What is this area known as? This is the site of incision. So this has been named as incisura terminalis. This is known as incisura terminalis. So this is the site of incision in end-oral procedures of the ear. The skin on the pinna is very tightly attached to the underlying pericardium. Yes or no? Yes. Now just feel your pinna. This is the lateral surface and this is the medial surface. Now just feel your pinna. Let me know that skin on this side of the pinna is very tightly attached. This side of the pinna is a little loosely attached, which means that on this side of the pinna is there hardly any subcutaneous tissue beneath the skin, and on this side of the pinna there is some subcutaneous tissue beneath the skin. Feel your pinna. Let me know. Yes. Where it is more tightly attached is the lateral surface. More loosely attached is the medial surface. Yes. So what is the significance of knowing that it is very tightly attached to the underlying pericardium? Are you noticing what I'm saying? It is tightly attached to what? The underlying perichondrium. Perichondrium that is lying on the cartilage. What is the significance of this? The significance of this is that a little scratch here. Yes. What will happen? The infection, if occurs, will directly go to the perichondrium, lead to perichondritis. Any trauma here on the pinna, what will happen? It will lead to rubbing of the skin over the perichondrium, directly on the perichondrium. That will lead to leakage of blood from the perichondrium. In the perichondrium, through the perichondrium comes the blood supply of the cartilage. That will lead to hematoma of the pinna. So on this side of the pinna is the skin more tightly attached. In other words, on this side of the pinna is hematoma more common. On this side of the pinna, if you itch or if there is injury, is perichondritis more common. Yes? It's a lateral surface. So that is again another thing that we need to know, that skin on lateral surface is more tightly attached. Tightly attached to what? To perichondrium. So that is why here infections, perichondritis, or hematoma will be more common. Both these will be more common on lateral surface of the pinna. That is why this pinna cartilage is very sensitive to temperature changes, very sensitive to pressure changes. In fact, 2 days back I had a patient. It was a child, around 7 to 8 years child, and what was the complaint? She cannot sleep on her pillow. Why? Because the moment she lies, the pinna starts paining. Yes, because of pressure. It was the cartilage of the ear becomes so sensitive to pressure, because just below the skin we have the cartilage. No muscle, not much subcutaneous tissue to support it. So as we can see here, yes, this is following piercing of the ear. The perichondritis has developed, and since it is a single cartilage, the perichondritis, if it occurs, it will not involve only a small area, it will involve the whole of the pinna cartilage. That is why piercing is never recommended in the cartilaginous part. You can do it only in this part, which does not have any cartilage, which is only fat. Yes. Now, in some people, there is a variation of the anatomy which is considered as normal, and that is what is known as Darwin's tubercle. Now, what is a Darwin's tubercle? It is a projection that you're seeing here, that is marked with the arrow at the junction of the upper one-third. So, the one-third of the helix of the pinna. And what is it an indication of? It is an indication of atavism, that we have descended from Yes, from apes. Yes. So what is the significance? We already know that, no? Yes, the significance is that this is used as a personal identification mark. So being a doctor, sometimes if it is written that in some patient for forensic purposes that this patient has a Down's tubercle, you should know what exactly Down's tubercle is, and secondly, where to look for it. So what is Down's tubercle? We know that, and where is the location was your in your exam. So it is at the junction of upper 1/3 and lower 2/3 of helix. This is the site. This is the site. So now keep your pens down. Yes, and quickly you are going to answer all these questions. Yes, pinna double stop. First touch, second touch. Which part of the pinna is from first touch? Yes, the trainers. Okay, now I'm going to mark some structures. You are going to tell me what they are named as. Yes, this area in between the helix and the antihelix. What is it? Yes, scapha. Very good. What is this area? This where I'm making the star. What is this? Very good, Simba concave. What is the significance of Simba concave? Significance of Simba concave? Tell me, Alex. This is the site. This is the site. So now keep your pens down. Yes, and quickly you are going to answer all these questions. Yes, pinna double stop. First touch, second touch. Which part of the pinna is from the first touch? Yes, the tragus. Okay, now I'm going to mark some structures. You are going to tell me what they are named as. Yes, this area in between the helix and the antihelix. What is this? Yes, scapha. Very good. What is this area? This where I'm making the star. What is this? Very good, Simba concave. What is the significance of Simba concave? Significance of Simba concave? Cartilaginous landmark for antrum. Tell me the bony landmark. McEwan's triangle. Yes, it end oral approaches. What is the site of incision that you give? Yes, incisura terminalis. Where is incisura terminalis? Yes, above the tragus. Yes, this is the site which is devoid of any cartilage. What's the most common site of preauricular sinus? Is it tragus? Is it antitragus? Where is antitragus? Yes, this area is the antitragus. So is it antitragus? Is it tragus? No. What is the most common site? Yes, the most common site is the root of the helix. The root of the helix. That is the most common site here. Skin on this side of the pinna is more tightly adherent to the underlying perichondrium. Lateral or medial? Yes, on the lateral side. On the lateral side. So a hematoma or a perichondritis of the pinna is more common on which side? Is on the lateral side of the pinna. So that is what we needed to know in the anatomy of the pinna. So now starting with the anatomy of the external auditory canal, can you please tell me first what is the external auditory canal developing from? Yes, external auditory canal develops from?
I'm so annoyed with this guy. ஹலோ டேய் சேஃபா இருக்கியாடா சைக்ளோனு நீ ஃபிளாட்ல தானே இருக்க உனக்கு பிரச்சனை இல்லை தெரியும்டா ஆனா இந்த எங்க பாட்டி வீடுலாம் கொஞ்சம் லோ லைன்ல, அவங்க வீடு ஃபுல்லா தண்ணி வந்துருச்சு. ஃப்ளாட்னா ஒரு அளவுக்கு அட்லீஸ்ட் தண்ணி வராம இருக்கும்ல. வீடு அப்படியா? டெரஸ்ல இருந்தா? ஐயோ! அதான் சன்னி ஆயிடுச்சுன்னு சொன்னேன் கேள்விப்பட்டேன். சரி ஓகே. 5th டிசம்பர் 5th டிசம்பர் ஆயிடுச்சுடா. இன்னும் கிண்டில் வரதுக்கு கொஞ்சம் டைம் ஆகும்டா. அது கரெக்ட்டா I'm not sure. It should take like 5, 6 daysல. அவன் வேற ஊர் ஓடி போறேன்னு அவன் பிளான் போட்டுட்டு இருக்கான். அவன் ஊருக்கு ஓடிலான்னு பாக்குறான் அவன் தஞ்சாவூருக்கு. So அவன் கேட்க மாட்டான்டா. He doesn't like being here. எப்போ சான்ஸ் கிடைச்சாலும் ஓடிடுறான் அவன். கேட்டா அது என் இடம், வீடு, எனக்கு பிடிச்சிருக்கு, என் பெட்டு, எனக்கு அங்கதான் இருக்கணும், துணி துவைக்கணும், ஏதாச்சும் ஒரு ரீசன் சொல்லிட்டு போயிடுறான். அது கொஞ்சம் சீக்கிரம் ஆர்டர் பண்ணா முடிச்சிடலாம்டா. அவன் இங்க இருக்கும்போதே குடுக்க அக்ரி பண்ணிட்டாங்களே, அவங்களுக்கு பிரச்சனை இல்லை. 1500 4 பேரு. அப்புறம் நீயும் சல்மானும் 1000 ஈச் தானே? சரி ஓகே. சரி அனுப்பிடு, இன்னைக்கு நைட்டுக்குள்ள பண்ணிடலாம். இன்னைக்கு ஆர்டர் போட்டுரு. ஓகே சரி, சேஃபா இரு. ஓகே பாய்.
Yes, it is a cleft that is going inside. So it develops from the first cleft. Yes, you cannot forget what we've already done. You have to revise, and revise. That is the only key to remembering whatever we have already read. So yes, it develops from the first cleft, and external acoustic meatus develops from from the first arch. Yes. Okay. Now external auditory canal abnormality or developmental abnormality of the first cleft. Can you tell me one? Yes, called oral fistula. Which part of the external aortic canal is present at birth? Present at birth? Yes, the cartilaginous part. The cartilaginous part is extension of cartilage of pinna. Along with the pinna, it is present at birth. The bony part develops later on. So at least we know that the external aortic canal has two parts. It has a cartilaginous part. It has a bony part. Now there is one question that you very commonly get confused, that when it is asked which part of the external aortic canal is cartilaginous, which is bony, lateral, medial, 1/3, 2/3. Now there is nothing to get confused at all. Which part, can you tell me, is cartilaginous, lateral or medial? Yes, we know, we already remember that the external aortic canal cartilage is the extension of the cartilage of pinna. So that is present along with the pinna, which means that is the outer part. Yes, so the inner part or the medial part will be the bony part. Now, what is the main function of the external aortic canal? Is transmission of sound from the air outside to the middle ear, to the ear inside. Yes, so which means that most of the external aortic canal should be cartilaginous or bony. It should be cartilaginous and collapsible, or it should be stiff and bony. What do you think? Yes, it should be stiff and bony, which means most of the external aortic canal has to be bony. Yes. So which part of the external aortic canal is cartilaginous? It is the outer 1/3. Which is bony? It is the inner 2/3. So the length of the external aortic canal is around 24 millimeters. Outer 1/3 becomes 8, inner 2/3 becomes 16 millimeters. So now whenever we think of external aortic canal, we are going to remember this diagram that we are going to draw now. So here we have the pinna. Yes, and now starts the external aortic canal. So in this part, the external aortic canal will be cartilaginous or bony? Yes, it will be cartilaginous. How much is it? Yes, it is 8 millimeters. It is outer 1/3. outer 1/3 8 millimeters. Now, what is the significance? What's the clinical significance of this part of the external aortic canal, the cartilaginous part of the external aortic canal? Now, here, the lining epithelium in the cartilaginous part is the same as the pinna outside. What does it mean? It's a very thick skin as here, thick skin as the skin of the face. That goes to line the pinna, that goes to line the external aortic canal, the cartilaginous part. Which means in the cartilaginous part, the skin is thick and it contains all the skin appendages. Which means what are the skin appendages? The hair follicles, the sweat, the sebaceous glands. So here we have the hair follicles. We have the sweat and sebaceous glands. Yes, and also additionally, we have additional gland responsible for production of cerumen, which is called as wax. Yes, so these are the ceruminous gland. So here we have hair follicles. We have hair follicles. We have ceruminous glands. So can you tell me the significance of this? If there are hair follicles here, so what? Yes, this is the area where folliculitis of the hair follicles can occur, which we call as furuncle. So if there is a furuncle in the ear, it will be localized only to which part of the external aortic canal? Only to the cartilaginous part. Then what is the lining epithelium of the bony part? Yes, please remember the whole of the external aortic canal, be it cartilaginous or be it bony, it is lined by stratified squamous keratinizing epithelium. Stratified squamous keratinized epithelium. Yes, everywhere it is stratified squamous, but the difference is that in the cartilaginous part it is very thick and it has all the skin appendages, whereas in the bony part it is very thin, just lining, a very thin lining over the bone of the bony part of the external aortic canal, and it does not have any skin appendages, no hair follicle, no sweat, no sebaceous, and no ceruminous glands. Yes, what is the significance of? Yes, so furuncle will be present only in the cartilaginous part. Ceruminous glands. So, what is the significance of this? Yes, this produces wax. Yes, so the production of wax occurs only from the cartilaginous part. It does not mean that you will not see wax in the deep part. It is produced from the cartilaginous part. When it is produced too much, it can go and it can occupy the deep part, but it is not produced from the deep part of the external aortic canal. That is why it is said don't use a earbud. We never recommend earbud. Why? Because if it is produced from the cartilaginous part and if you do not do anything, ears are usually self-cleansing, the wax will come out. Whereas if you put a bud, what will happen? You will push it deep into the bony part and then it will go and get collected there. Yes. Now, another important thing in the anatomy of the external aortic canal we need to know is that here in the anterior wall towards the floor are two openings. They are known as fissures of Santorini. Fissures of Santorini. What's the significance of these fissures of Santorini? Yes, if there is any infection of the external aortic canal which goes out from the fissures of Santorini, where does it go? If any infection goes out from the external aortic canal through the floor, where does it go? Do we remember the anatomy? Yes. Can you see here? This. Do you remember this? Yes, we saw that the whole of the ear is like a tunnel in the temporal bone. The roof is the part of the base of skull where we have the multiple openings for the cranial nerves, and this is the part of the floor. This is the part of the floor. This is again a part of the base of skull, which means if any infection comes out from the floor of the external aortic canal, where has it gone? It has gone into the base of skull. Yes or no? Yes, it has gone to the base of skull. And one of the otitis externa is known as skull base osteomyelitis because when it goes out of the skull, out of the floor, it goes directly into the skull base. And also, just see here. Just here anteriorly, we have the parotid. Can you see here? So if any infection goes out from the external aortic canal, if it goes and involves the soft tissue structure, what will that be? Is that will be involvement of the parotid. And also the parotid tumors through these fissures can project into the external aortic canal. Yes, we had a patient who had the complaint that whenever she puts her finger into the ear, she can feel something. And when we examined, what we saw was in the area anterior and in the floor. Towards the anterior wall and towards the floor, towards inferiorly in the anterior wall, we saw a mass. Yes, so is in that area, if there is furuncle, there will be pain. It has been there for years. So then, to rule out it was an elderly female, we got a CT scan done. Why? Because we had that in our mind that this is a foramen which is a continuity to the area of the base of skull. So what is it? Some mass that is coming through this foramen inside into the ear canal. And do you know what it came out to be? It was adenocarcinoma of the parotid which was projecting. So here is a question that is asked in your exam that an otitis externa can lead to parotitis. This can happen through fissures of Santorini. Any otitis externa can lead to skull base involvement. This can happen through fissures of Santorini. So from the fissures of Santorini, the infection can go to the base of skull, and second is to the parotid. So whatever anatomy we are doing, what we are doing is the clinical anatomy. We are seeing the clinical significance of each and every part of the anatomy, and that is what you need to know whenever you study anatomy also of any part, and that is what is asked in your exam. So this is what we need to know in the cartilaginous part of the external canal. Now where the cartilaginous part ends, here we'll start the bony part, right? So the junction of the cartilaginous and the bony part of the external canal is the narrowest part of the external canal. True or false? Yes, just see anybody's here and see, are you seeing the narrowest part so close laterally? No. The narrowest part of the external canal is not the junction of cartilaginous and bony. It is present deep in the bony part. Yes, and this narrowest part is what is known as isthmus. Isthmus. This is the narrowest part of external artery canal. And now here we will have the tympanic membrane. Okay, so what will be the significance of this narrowest part? Why do we need to know that this is the narrowest part? Yes, because if at all any foreign body goes medial to it, where is this narrowest part isthmus not present? It is just around 5 to 6 millimeters lateral to tympanic membrane. So if any foreign body goes medial to it, it will usually get impacted, which means it will not be able for you to bring this foreign body out very easily just by syringing. Just by putting the pressure of water, that is what we do to remove the foreign bodies of the ear. It will not come out. You will have to go for surgical instrumentation to remove a foreign body which has gone medially, which has got impacted. So this here is the bony part. This here is the bony part. And the bony part, can you tell me how much is the length of the bony part? Bony part is the inner, that is the medial, 2/3. 2/3 means how much? Medial, 16 millimeters. Now just beyond this narrowest part, that is the isthmus, the external artery canal in the bony part dips down to form a recess. A recess, what's the significance of this? That any pus that is coming out from the middle ear can collect here. Yes, so this is what is known as the meatal recess. Meatal recess. So this is just a dilatation in the floor just beyond the narrowest part, that's the isthmus. Now another thing that we need to know here in the bony part is, like in the cartilaginous part, we have in the floor towards the interior wall, we have the fissures of Santorini. Similarly, in the bony part also during development are openings in the floor present, and these are known as foramen of Haschke in the floor. They are known as, in the cartilaginous part was known as Santorini, here it is known as foramen of Haschke. Foramen of Haschke. What is the significance of foramen of Haschke? Same like fissures of Santorini. Any infection, if it goes out from here, it can go either to the base of skull or it can go to the parotid. So this is what we need to know. In this one diagram, you have everything about what you need to know in the external artery canal. Now, one practical thing that we use always whenever we have to see the tympanic membrane from the external artery canal is, and that is something which you are asked always, is that if you just start seeing from the external artery canal here, will you be able to see the tympanic membrane directly? Yes or no? No, you will have to pull the pinna upwards, superiorly and posteriorly. Why so? Why so? Yes, just see here. The external artery canal is not in a straight line. It is in the form of a S. So suppose I'm showing you my right external artery canal. The cartilaginous part goes upwards, backwards, and medially. Right, yes. And the bony part goes downwards, forwards, and again medially. So if I'm standing here and I want to see the tympanic membrane which is at this end, at the other end, how do I see it? Yes, can I move the bony part? Can I move the bony part somehow? No, I cannot. Can I move the cartilaginous part? Yes, I can move the cartilaginous part by moving the pinna because this is the same cartilage as the pinna. So how do I move the pinna? Yes, I will move the pinna upwards and backwards. Yes, I will move the pinna superiorly and posteriorly. So now the external artery canal will become a straight line, and now I can see straight. I can directly see the tympanic membrane standing at the external opposite. So this is another important thing that we need to know. The direction of the OPC. Yes. So in the cartilaginous part, we go upwards, backwards, and medially. And in the bony part, it is downwards, it is forwards, and again medially. So how do I have to pull the pinna? It has to be posterior or superiorly. Posteriorly and superiorly. So up and back, posterior, superiorly. That is up plus back. Yes. So quickly, tell me in the external artery canal, what are the things that you need to know? Tell me in the cartilaginous part. Yes, cartilaginous part is the lateral 1/3 or medial 2/3. Lateral 1/3, medial 2/3. Yes, it is the lateral 1/3. Yes. Quickly tell me, furuncle of the external artery canal will be localized only to which part of the external artery canal? Furuncle. Only to the cartilaginous part. Furuncle. Gas is produced from which part of the external artery canal? Yes, only from the cartilaginous part. Narrowest part of the external artery canal is, isthmus. Isthmus is in the cartilaginous or the bony part? Yes, that is in the bony part. Cartilaginous part is how many millimeters? 8 millimeters. Yes, the bony part is lateral 2/3 or medial 1/3. Tell me, lateral 2/3 or medial 1/3? Incorrect choice? Yes, it is incorrect. Correct, and then it is medial 2/3. It is medial 2/3. Medial 2/3. That is how much? That is 16 millimeters. Yes, the narrowest part is isthmus. Isthmus. Yes, if the foreign body goes medial to it, it will get impacted. So can you tell me the deficiency in the floor of the cartilaginous part? Santorini. In the floor of the bony part is known as Haschke. So in the cartilaginous part, we have Santorini. In the body part, we have Haschke. We have Ashki. And how we pull the pinna to see from the external aortic canal to see the tympanic membrane? Yes, that is posteriorly and superiorly. So that is what we need to know in the external aortic canal. Now let me show you one picture and ask you something. Yes, can you see here? This is a picture of the external aortic canal, endoscopic picture. We are seeing here a localized swelling here. Can you tell me if this is an extension of the parotid tumor? Can you tell me if this is an infection that has extended from the parotid or from the base of skull? Yes or no? Cannot be. This is in the roof, and where are the fissures centering? Yes, so otitis externa can become parotitis, or parotitis can become otitis externa through fissure centering that will be present near the floor. That will be present anteriorly and also near the floor of the external aortic canal, not in the roof. Then can you tell me what this swelling is? Yes. What is this? We can see this is a localized swelling only in the cartilaginous part. Why do I say cartilaginous part? Can you guess this is the cartilaginous or the bony part? Tell me. Yes. Are you seeing the hair follicles here? So this has to be which part? Here's the cartilaginous part. And this is only localized to the cartilaginous part. In the deep part, we are not seeing anything. We can see the tympanic membrane here very clearly. So this is a localized swelling of the cartilaginous part. Tell me the diagnosis. Yes. Can it be a furuncle? Yes or no? Yes, this is a furuncle. What else can it be in this area in the external aortic canal? Yes, so this is a furuncle. So very good. So when we know this, this is how the anatomy, this is how it helps us to come to a diagnosis clinically. So now starting with the anatomy of the tympanic membrane. Yes, quickly can you tell me tympanic membrane develops from? Yes, it develops from all the 3 layers of the embryonic disc. Tympanic membrane is how many layers? Yes, it has 3 layers. Now tympanic membrane is the window of the middle ear. It is the common wall between the external aortic canal and the middle ear, so it can be affected in both conditions of the external aortic.
Awesome. Thank you.
Number 8.
I did it. Yeah.
ஆஃப்டர்நூன் சாப்பிடலன்னா
என்னது இது?
பாதம்
பாதாம் அல்வா.
கெட்டு போயிடும். இன்னும் ஒரு நாள் கூட சாப்பிடு.
हाँ அப்படியே எழுது பரவாயில்ல ஒன்று ரெண்டு தப்பான ஹலோ குட் ஈவினிங் ஜெஃப்ரி என்ன பண்றீங்க ஃப்ரீயா என்ன பண்றீங்க சரி 8 மணிக்கு வீட்டுக்கு வாங்க சிக்கன் பிரியாணி செஞ்சிருக்கேன் ஆமா பாட்டி செஞ்சிருக்காங்க பசங்க ட்ரீட்டா யாருக்கு கூப்பிடவே இல்லையே என்ன ப்ரோ இன்னைக்கு வேணாம் ஜி நீங்க இன்னைக்கு வாங்க வீட்டுக்கு வாங்க நல்லா ஃப்ரெஷ்ஷா செஞ்சுக்கோ உங்களை மட்டும் தான் கூப்பிட்டுருக்கேன் நம்ம 2 பேருக்கு மட்டும் தான் இருக்கு ஆமா அஃப்ரத்தை கூப்பிட்டா பாலா மொத்த சிலகேஷும் வந்துடும் அஜய் அப்புறம் கரெக்ட் அதான் நீங்க தனியா இருக்கீங்கன்ட்டு ம் வந்துருங்க வந்துருங்க சாப்பிட்டு உங்களை ட்ராப் பண்ணிடுறேன் நான் அப்படியே ஹாஸ்டல் போயிடுறேன் 8 மணி வாங்க ஜி நீங்க எப்போ சாப்பிடுவீங்க அந்த டைம் ஓகே சரி என்ன படிக்கிறீங்க சரி ஓகே நான் முடிச்சிட்டேன் ஆமா ஒண்ணுமே இல்லை 1 மணி நேரம் தான் அப்படியே அழகா எழுதி வச்சுக்கோங்க அப்புறம் சீக்கிரம் எழுதிட்டீங்கன்னா கிளம்பிடலாம் நீங்க ஊருக்கு நீங்க இருக்க தேவை ம் ஓகே 8 மணிக்கு வந்துடும் சரி பாய்
canal as well as conditions of middle ear. So it is very, very important for us to know how the normal tympanic membrane looks like. Only then we will be able to know that this is abnormal, and this is abnormality of the external ear, this is abnormality of the middle ear. So suppose this is my tympanic membrane, right? This is my right tympanic membrane. Just forget that this is my hand. Think that this is my right tympanic membrane. So this here is the surface that faces the external canal, right? This is the external canal here. So this surface which faces the external canal, this is what is known as the lateral surface. This surface which faces the middle ear is the common wall between the external aortic canal and the middle ear. Yes, so this surface which faces the middle ear, this is what is the medial surface. This is the border that faces my face. Yes, so this is the anterior border. This faces posteriorly the mastoid, so this is the posterior border. This faces the roof, this is the superior border, and this is the inferior border. So we saw that tympanic membrane has two surfaces, lateral and medial, and it has four borders here. Yes, now this tympanic membrane is not exactly like this. It is like this. Like this means it is at an angle with the horizontal. That angle is 55 degrees. It is at an angle of 50. Degrees with the horizontal. Now this is not exactly like this, also it is like this. What is the meaning of like this? What do we have here? External canal. Yes. So the posterior and the superior part is more towards the external canal. Was a question asked in the exam? Which wall of the external canal is longer? Which wall is longer? Yes. Which is longer? So here if you have the external canal and the posterior superior part is more towards the external canal, which becomes longer? Yes, the anterior part. The anterior and the inferior part is longer of the external canal as compared to the posterior and superior part. And how is this medically significant to us? If the posterior and superior part is more towards the external canal. Yes, which is the more accessible part of the tympanic membrane. If you're standing at the external acoustic meatus and you want to access the tympanic membrane to remove a pus from the middle ear. If there is pus in the middle ear, to remove it, you have to give incision on the tympanic membrane. So if you have to give incision on the tympanic membrane, which part of the tympanic membrane will you choose to give incision? Which will be more easily accessible to you? Is the posterior part. Yes, so that is why whenever you want to remove the pus, incision is given there on the posterior part. Now this is not exactly like this also. It is tented in the center. It is dipped inside in the center, which means that the outer surface becomes like a concave. It becomes concave. It is dipped inside. It is tented in the center where it attaches to the tip of the handle of Mealyus. And when it attaches to the tip of handle of Mealyus, this is what is known as umbo. This is umbo. Now this tympanic membrane is divided into two parts, lower 2/3 and upper 1/3. Okay, so now let us have a look at the tympanic membrane. What do we already know till here is that what is the center part known as? Where it attaches to the tip of handle of Mealyus. Yes, this is what is known as the umbo. We know that. Yes. What is the angle with the horizontal? That we know, that is 55 degrees. Okay. Now this tympanic membrane is divided into two parts, a lower 2/3 and an upper 1/3. Now the lower 2/3, in the lower 2/3, the fibrous layer of the tympanic membrane is very well developed. And all around this fibrous layer, it thickens to form a thick ring which is known as fibrous annulus, and that fibrous annulus tightly fits into the depression of the tympanic bone all around, which is known as tympanic sulcus, making the lower 2/3 very tight, very tense. Hence this is what is known as pars tensa. Whereas in the upper 1/3 there is no tympanic, there is 2/3. In the lower 2/3, the fibrous layer of the tympanic membrane is very well developed. And all around this fibrous layer, it thickens to form a thick ring which is known as fibrous annulus. And that fibrous annulus tightly fits into the depression of the tympanic bone all around, which is known as tympanic sulcus, making the lower 2/3 very tight, very tense. Hence, this is what is known as pars tensa. Whereas in the upper 1/3, there is no tympanic, there is no annulus, tympanic annulus is missing here. So this is where it is missing, the tympanic annulus is not present, is what is known as notch of Rivinus. So in the upper 1/3, the fibrous layer is very sparse, making the upper 1/3 very mobile, very flaccid. That is why the upper 1/3 is what is known as pars flaccida, or this is also known as Sharpner's membrane. So what is the clinical significance of this? Let me ask you. If there is a retraction on the tympanic membrane, if there is a retraction pocket that is formed on the tympanic membrane, which is the most common site where a retraction pocket will form? Yes, in other words, which is the more mobile part of tympanic membrane, pars tensa or pars flaccida? Yes, more mobile is pars flaccida. This is more mobile. Yes, also a retraction pocket will be seen most commonly here. Retraction pocket will be more common here. Why? Because this is more mobile. Okay, so tell me which is the more mobile part of tympanic membrane? Pars tensa or pars flaccida? Yes, it is the pars flaccida. Very good. Okay, so which is the more mobile part of pars tensa? In the pars tensa, which is more mobile? Center or periphery or paramedian, which is more mobile? We know that in the center, tympanic membrane is attached to the ulna, and we also know that in the periphery also it is tightly attached to the tympanic sulcus. Yes, so which becomes the more mobile? Yes, the paramedian. Paramedian. So in the past tense, most mobile is paramedian part. Is paramedian. Now, suppose paramedian is not there in your choice, and what is given in your choice is which is more mobile part of pars tensa, and the choices are center or periphery. So, what will you mark? Center or periphery? Center definitely we know is umbo, that is fixed. So, what becomes more mobile? The periphery. So this becomes the periphery. Yes, so periphery is more mobile as compared to the center. It becomes like a tent. So what we are seeing is that the whole of the tympanic membrane does not vibrate equally everywhere. Yes, so that is why the effective anatomical surface area and the effective vibratory surface area is different. So the anatomical surface area of the tympanic membrane, anatomical surface area of the tympanic membrane is, it is 10 millimeters, 9 millimeters, and it is 0.1 millimeters in thickness.
Ah,
Total sub-
yes. Ah. Yeah, 1 second.
equally everywhere. Yes, so that is why the effective anatomical surface area and the effective vibratory surface area is different. So the anatomical surface area of the tympanic membrane, anatomical surface area of the tympanic membrane is, it is 10 millimeters, 9 millimeters, and it is 0.1 millimeters in thickness. Total surface area is around 90 millimeters square, whereas the effective, because all of the tympanic membrane does not vibrate effectively, the effective vibratory vibratory surface area is only 55 millimeters square. And what else on the tympanic membrane is 55? Yes, the angle with the horizontal, that is also 55. Now on this tympanic membrane, we are seeing some projection here. What is this projection? Yes, this is another process of the Méliès. Process of Méliès. So what are the process of the Méliès? Yes, just have a look here. So here we have the Méliès and here we have the tympanic membrane like this. Yes, so this Méliès has a head and it has a neck and it has, this is what is known as the handle of Méliès. And the tip of handle of Méliès is attached very tightly to the tympanic membrane. This we know is known as ampule. Yes, and also the tympanic membrane is very tightly attached on another part of the Méliès that projects laterally. Laterally means where tympanic membrane is this. What is lateral to it? Is the externotary canal. So the part of the Méliès that faces the externotary canal, that is what is it's known as a lateral process. The Méliès also has a
So many distractions, man. Hello, mom. Hi, mom. Hello, mommy. Signal ரொம்ப பேடா இருக்கு, mom. Your signal. அப்படியா? இல்லையே. Your voice is like very grainy. Can you call me again? Cut and call.
process which faces anteriorly. That is what is known as
Hello. Now it's okay. சரி என்னமோ. No. No, I'll have till 50. No, I cannot because it's like the second time I'm calling. அம்மா குடுக்குறேன்னு சொல்லிட்டாங்கம்மா. இதுக்கு மேல சும்மா நோண்டி கேட்டா they'll just say after 10 days, 10 days. Can you just wait, please? I'm not going to call. I can't. I don't want to keep calling them, mom. It's such a irritating thing. They just say 10 days, 10 days. Can you wait? They're literally saying, indirectly saying, shut up and just wait. We'll do it for you. அது வரோமா, வெயிட் பண்ணுங்கம்மா, வரோமா. It's holiday season. ஸ்லோவா தான் பண்றாங்க. Just wait. It is official. If FCB has passed, then it's really passed. அவன்தெல்லாம் வராதுப்பா. FCBS தான் வந்துச்சு. Yeah, I told you. Yeah, they also passed. Yeah. I think 2. Yeah, it's because I asked one guy to write and Monish, I convinced him to write. Yeah, I told him first year and he's been doing this. Yeah, but he's a selfish guy. He will not help. He will only use you as money. Yeah. 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 Anything important, mom? Studying. Middle of study session. I promise you, I'm live streaming it also. Okay, I'm sending. Bye.
Entire process. So this is what is the entire process, and this you're facing laterally towards the tympanic membrane, towards the external canal. This is what is known as the lateral process of Méliès. So yes, the tympanic membrane, on the tympanic membrane, we will see a projection, another projection of the Méliès, and this is what is known as the lateral process of Méliès. And also note here that from the umbo,
Hi, Mom.
from the umbo, in the anteroinferior quadrant
Love you, Mom.
is a cone of light. This is what is known as cone of light, and this is seen in the anteroinferior quadrant. It is seen in the anteroinferior quadrant. This is because of the obliquity of the tympanic membrane. There's a reflection of the handle
I have
of
a sore
Méliès.
throat.
So these are the things that we need to know about the tympanic membrane. Now let us quickly have a look at the normal tympanic membrane. Yes. So
I have a
why do
sore
I say
throat.
this is normal? Is it appearing normally? So what is the normal color of the tympanic membrane? Yes, what is the normal color? If this was red, would I have told that this is normal? If it was pinkish, if it was blue, no, what is the normal color then? Yes, the normal color is it is pearly white or it is pearly gray, and it is also translucent. Can you see that through it? You can get a little glimpse of the middle here. So it is pearly white or pearly gray, and it is translucent.
Because a guy coughed at me in the theater,
And
I
it's
got a sore
translucent.
throat from that.
Okay, now
I
whenever
had an
you are
antibiotic,
given
now
a
it's
tympanic
better.
membrane like this in your exam, what is the question that is asked? It is asked, this is which tympanic membrane? Also, whenever in your any case presentation you are given a long case or a short case, you are definitely going to get some case of the year. So there, the examiner tells you that draw what you are seeing on the tympanic membrane. So for drawing, what you have to draw is which year is the pathology present. You have to draw, and just by your drawing, it should be
I
evident
Google
which year
solved
you have
Pokemon.
drawn.
Now it's a lot
Yes,
better.
it
Trust
is.
me.
The tilt will tell you it is which year. So what you prefer usually is you draw over straight.
And I
Just
did
to avoid
exercise
any
today as
complication
well.
which year it is. No, that will not do. It is very, very simple. Just consider the tympanic membrane like a clock. Yes, like a clock. And there
I
we
had all
have
that.
the
And I
long
did
arm of
exercise
the
as well.
clock, like this. This is the handle of Méliès. Consider this as the long arm of the clock. This one, yes. And just what you have to see is whether this arm is pointing towards the right or it is pointing towards the left. It is pointing towards the right or it is pointing towards the left. Yes, this is right or left means I am talking about the right or left part of the page. This here is my right side of the page and this is the left side of the page. Yes, so if it is pointing towards the right, this is the right tympanic membrane. If it is pointing towards the left, it is the left tympanic membrane. It is that simple. Yes, can you imagine? Now, another important thing that the direction of the handle of Méliès point tells you is that first, which tympanic membrane, and second, wherever it points towards, that is the anterior part. That is the anterior part of tympanic membrane. Now, why is that important to know which is the anterior part and which is the posterior part? Yes, I will just tell you that. Before that, you just tell me which is this tympanic membrane. Is this the right tympanic membrane or the left? So this is pointing towards the, yes, right. So this here is the right tympanic membrane. Now, can you tell me in this tympanic membrane, which is the anterior part, which is the posterior part? This is anterior or posterior? Or this is anterior or posterior. Okay, so you will tell me that, okay, I'm seeing the cone of light and I know cone of light is in the anterior quadrant. So I can tell that this is the anterior part. Now, if I show you this tympanic membrane, here you're not seeing any cone of light. Can you now tell me which is the anterior part and which is the posterior part? And this is a tympanic membrane where it is important for us to know which is the anterior part and which is the posterior part. Why? Because this was a question of the exam. This endoscopic picture of the middle was given and was marked this and was marked this and was asked that the marked structures are what. So whenever you have to see what the structures are in the middle here, the first thing that you need to see is that the marked structures are in which part of the middle here, anterior part or the posterior part. Once you've localized that this is the posterior part, you do not have to think of all the structures in the middle here and then come to a diagnosis. Yes, you can localize, okay, this is the posterior part. So in the posterior part, we have only 1, 2, 3, 4. These structures, I have to just choose among them. Okay, this is the anterior part, so I have to just choose among 1, 2, 3. Only these 3 I can think of. I don't have to apply my mind to think of 10 things. Is that clear? So what we need to know what the direction of the Méliès tells us, the upper end of the Méliès tells us, is the pointer. What it tells us is first, it is pointing towards this side. So can you tell me this tympanic membrane, right or left? Very good. This is the right tympanic membrane. Right tympanic membrane. Can you tell me which part is anterior? This or this? Which is anterior? Yes. So whichever side it points, that is the anterior. So it is pointing towards the right side. This is the anterior part, and this is the posterior part, which means that all the structures that has been marked is in the posterior part. I need not apply my brain to think what the structures are, all the structures in the middle here now. Is that very clear? So now quickly you're going to draw the left tympanic membrane for me. Quickly take out your pen quickly, yes. Draw the left tympanic membrane. Left tympanic membrane. Yes? Yes, have you drawn something like this? Yes, the handle of Méliès tilt, the upper end. The upper end on the handle of Méliès here, it is pointing towards the left. Yes, so which will be the anterior? Where should I draw the cone of light? Yes, I will draw the cone of light here because here I know that this will be the anterior part. Have you drawn something like this? Yes. Now, when we draw like this, what is this? What are these parts? These are what are known as malleolar folds. History will tell you that the fibrous annulus, the annulus, that is the thickening of the fibrous layer of the tympanic membrane, is present only in the pars tensa. It is absent in the pars flaccida part. Here we do not have any the fibrous annulus. Yes. So this fibrous annulus here, the fibrous layers, they go and attach to the lateral process of the Méliès. These are what are known as malleolar folds. These are known as anterior and posterior malleolar folds. So now, fibrous annulus. Yesterday I tell you that the fibrous annulus, the annulus, that is the thickening of the fibrous layer of the tympanic membrane, is present only in the pars tensa. It is absent in the pars flaccida part. Here we do not have any the fibrous annulus. Yes, so this fibrous annulus here, the fibrous layers, they go and attach to the lateral process of the Méliès. These are what are known as malleolar folds. These are known as anterior and posterior malleolar folds. So now, identify this tympanic membrane. Is this the right or the left tympanic membrane? See here? Yes, it is pointing towards left. So yes, this is the left tympanic membrane. Which is the anterior part? Here we can see the cone of light, so we can easily tell, yes, this is the anterior part. Even if it was a perforation, we could have made out which is the anterior part. Okay, now quickly keep your pens down. Yes. Now I'm going to mark a few structures here and you're going to quickly tell me what these structures are. Yes. So tell me this. What is this? Yes, this is very good. Ambo. This is what is that? That's the lateral process of Méliès. Yes. What is this? 3. What is this here? Yes, the cone of light. Cone of light is in which quadrant? Anterior quadrant. Now, in this, suppose this is a patient. Actually, this is not the tympanic membrane. Does not show that there is pus in the middle. By chance, there is pus in the middle here, and I want to give an incision. Where should I give? Should I give here or should I give here? Where should I give the incision? Yes, in which part? In the anterior part or the posterior part? Yes, so first we should know what is anterior and what is the posterior part. Here's the posterior part. We will give the incision in the posterior part. Which part of the tympanic membrane is more lateral? More lateral. Anterior or posterior? Yes, the posterior part. What is the center of the tympanic membrane where it is tented inside known as? Yes, Ambo. What's the angle of the horizontal? 55 degrees. What else on the tympanic membrane is 55? Effective vibratory surface area. What is the normal anatomical surface area of the tympanic membrane? Yes, it is 90 millimeters square. What is the color of the tympanic membrane? Pearly white or pearly gray? Is it translucent? Is it transparent? No, it is not transparent. It is translucent. Which is the more mobile part in tympanic membrane? Tensor flaccida. More mobile part. Flaccida. Flaccida is also known as sharpness membrane. Which is the more mobile part of pars tensa? Center or periphery? Yes, it is periphery. The retraction pocket is more common in pars tensa or flaccida. In the pars flaccida. So that is what we needed to know in the tympanic membrane anatomy.
Lovely.